cloud. So a little bit about Peony. You had mentioned that you work in the small group arena. Peony is a culmination of that 50 years of experience that we were talking about. It's fully integrated. So everything that touches the four corners of a plan document, we do in-house. One phone call on your ID card gets you all of the services I'm about to describe. So in a nutshell, on top of the fully integrated aspect, we're also the nation's largest privately held PBM. So there's a lot of backing when it comes to specialty and RX. Mm-hmm. Now, under Peony, on top of everything being done in-house, your members have the opportunity to receive basically really, really expensive typical operations for free. They don't need to change their behavior. I know a lot of the guys out there are saying, oh, we need to change healthcare, we need to do this, we need to do that. But we understand that the member isn't always going to fall into that bucket who's going to engage with us. Mm-hmm. So I'll share a little bit about how it works. That one phone number on the back of the ID card, you call in, it comes to our customer service. They're literally 100 yards away from me in the same building. They go through a series of questions, find out what's going on with the member, find out what's going on with the provider, if that's who's calling in. And based on the answers that the member or provider gives us, we can direct them to an advocate on that very same call. So if it's a member and he calls in saying, oh, I need a surgeon, I'm just checking my network benefits. Okay, well, that's a red flag to our customer service members. They'll get transferred to a Advanta advocate or a care advocate immediately on that same phone call. And the care advocate will educate them about how they can receive their surgery, their colonoscopy, MRIs, knee replacements, spinal fusions, all of that for free. Now, let's say it's a provider calling in. The provider will always call in because they want to get paid, right? Benefits and eligibility or prior authorization requirements. So the provider will call in and based, again, on the series of questions that are asked by our customer service staff, will identify where and what service is being taking place. That will all be logged down. And then at that point, we have the care advocate reach out to the member and say, hey, your provider just called in. It seems like you have a knee replacement coming up. Did you know that you can get it for free? There's no deductible, no copay, no co-insurance. It's free. And that's how we capture that information under the care advocate program. Now, that's the care advocate portion for the medical. We do the exact same thing on the pharmacy side as well. So the same process applies whether it's a member or a provider calling in to provide or prescribe a medication. We'll identify it, and anything over $1,000 will fall into our program called RAY. RAY is a specialty drug program. It's not just cherry picking like the Humiras of the world, right? We hit everything over $1,000. We'll reach out to the member, and because of our longstanding relationships with the manufacturers out there and through our connection of being a large PBM, we can basically tap into international sourcing, alternative sourcing, white bagging, brown bagging, MAP, PAP, copay assistance. Every opportunity to cost contain for the member on the market is done through RAY, and our advocates handle that whole stretch. So the member's experience is literally, I called in, next thing you know, they mail drugs to my house or to my place of work or to my doctor's office, and it was a great experience. It's completely handled from point A to Z by our advocate team. The same thing applies to the medical portion. It's a white glove concierge type service. Now, that's huge in itself, right? But what's also cool about Ray is we have a cash pay program. So a lot of times, I think the statistic is 15 to 50 cents. Don't quote me, 15 to 50 cents on the dollar when you get a medical procedure done in a hospital is actually allocated towards operations and collections. That's a huge portion, right? We're talking about a substantial sum of money. So what our team does is we offer cash up front for a service in order to secure guaranteed pricing, not just for the actual service, but from pre-service. So anything leading up to the surgery itself, the anesthesiologist, and then any type of post-service or post-surgery recovery that the member needs to go through. So I'll give you an example. There was a knee replacement. I think it was, a week and a half ago now. The provider had originally billed, I think, something to the tune of 65 or 70,000 just for the surgery. There was no bundled pricing. It was surgery alone. Here you go. Our team of advocates came in. They got all of the imaging work that led up to the surgery taken care of. They got the surgery, the anesthesiologist taken care of, and they got all of the PT under one bundled rate that was like less than $20,000 all in. We paid for it up front with our cash pay program. And the member basically got to, one, just walk in and have everything done for free. But two, we actually got one of the advocates, because it was maybe 2 weeks ago now, one of the advocates actually got a gift basket from the member just saying like, hey, thank you so much. It was a great experience. Like, I just got my knee replaced for free. The PT is going great. Thank you. And we see it happen all the time, but that's just like, one specific scenario. In other cases, because of our longstanding relationship with the provider market, we will fly people out to hospitals like Johns Hopkins because we do have a very strong relationship with them. And the way that we approach that type of situation is we actually will pay for everything and treat it like a mini vacation. Now, that means flight, like lodging. In some cases, we'll even fly out family members so that they have somebody with them there through the process, because it can be an ordeal when you're getting, a double lung or a heart transplanted. But that's all encompassing, right? It's part of our care advocate program. It's all free for the member. There is no deductible copay coinsurance at all. Now, that's awesome. I love talking about Ray, the cash pay, the specialty, and the care advocate program. And that's good for like the large scale stuff, right? We're talking about anything more than just, imaging, surgery, all of that is covered. But what about like, your routine visits? Well, we actually have our own telehealth platform that we launched, and, calling it telehealth is almost like an injustice. I like to call it a digital medical practice. If I'm being honest, it's robust. So we started out on this endeavor, and we wanted to make sure that it was changing telehealth, right? So all of the providers are W-2. They all have a mandatory requirement of 10 years real life practice experience. And the beauty there is that, one, they're not just logging on after a 15-hour shift, right, for a couple extra bucks. But two, we had real life, basically quality control. We could see how experienced these people were. So when we brought them onto the program, not only did we offer primary care, we actually extended that into 23 different specialties, including 24/7 mental health access. Now, that's all cool. That's all great. And a lot of people will say, well, Gio, that's probably like, what, $15, $10 PEPM a month in admin fee? And I go, no, that's a great question. You'd be right, but you're wrong. It's completely free. We pay for the cost. And from a member standpoint, anytime they go and visit this telehealth doctor, it's completely free. There's no cost to it, and there's no claims that are generated. So it's like a ghost claim, right? You have nothing that counts against your renewal, that standpoint as well. So those are just three of the super powerful offerings under the Peony brand, I guess. But in a nutshell, it's not value-based pricing, right? Peony does have value-based pricing, but what I just talked about was all PPO. I mean, our care advocates are securing contracts when we go out there. Same with the Ray advocates. There is no potential for a balanced bill. If you participate, or even if like, you don't have to participate, I say that, but like your provider could call in on your behalf, there is no opportunity for a balanced bill because we have contracts with all of these providers, all of these doctors that are prescribing and writing all of these procedures and medications. So I just threw a lot at you. Any questions for me so far?
What happens if a provider does not want to contract with Peony, has no interest in adding an additional billing partner or anything like that? How does that work?
Great question. So I guess one, we have our own proprietary network called Provider Network of America. It has over 1.2 million providers under direct contract, and we only launched in like 2017. I mean, historically, we've built and sold probably 5 networks at this point over our lifetime. But on Peony, the PPO solution is typically we'll go out with a PHCS extended PPO wrapped with PNOA. And the way that we designed PNOA was we looked at where all of the larger all of the larger networks were around the nation. And then if you can imagine those holes, we went out there and we contracted all of the holes. And then once we got that down, we started to contract in the same neighborhoods as the larger networks. A provider doesn't have to participate with our program in order for members to get their services for free. Okay. So let's say I need a knee replacement at Dr. Smith. Dr. Smith, my care advocate reaches out to him because he submitted some prior authorization paperwork or benefits and eligibility paperwork. Care advocate reaches out, and the care advocates will always try to negotiate with the originally scheduled provider. That's always their goal. We don't want to disrupt care. And we always try to keep it on the same timetable. So there is no delaying of care, if you will. If it's next week, we're getting you in next week, no matter what. So they'll reach out and they'll say, Dr. Smith, Gio has a knee replacement coming up. We can pay you right now over the phone for his knee replacement. Dr. Smith, in your example, says, no, I don't want that. I don't want to negotiate. Okay. So now, I guess they'll present me an option. Gio, you can either go to Dr. Smith, who's a contracted surgeon in the network, or we can provide you options in the same neighborhood, right? Like, we have Banner. Banner's a big hospital system here. But we have a whole bunch of other surgeon and like ASCs and like, what are they called? Excellent service locations.
Centers of excellence.
Yeah, centers of excellence. Thank you. In our accessibility, if you want to call it, like we have our own database of where we can send people, and we'll actually just call people to see if they're open to scheduling. But they'll present me the member options. So they'll say, Gio, you can go to Dr. Smith. He didn't want to participate. We offered him cash. We did all of these things. He just wants to continue with his contracted rate with the network. You're going to have to pay your deductible, copay, and coinsurance if you go with him, because we weren't able to establish a contract. However, 2 miles away from Dr. Smith, we can get you into a place with better service standards, lower infection rates, and it would be free. Same timetable, you're getting in next week. What do you want to do? And from HMA's perspective, whatever I say as a member, my response, I want to stick with the initial provider. I want to go and participate in the redirection, go pound sand to both of those options. I'm going to go to, Mexico or wherever I want to go for this knee replacement. Our care advocates actually log all of that information down. And for you as a broker, you can actually see that real time. Like our reporting shows you the engagement level of your members. So it's pretty cool when you're talking about renewals and they're like, hey man, our renewal is really high. And it's like, well, look at that. You had the opportunity 5 different times to participate in care navigation. And each time your membership elected to go not like out of network, right? So it gives you guys a really powerful tool when that next cycle comes up. Vice versa, if we've had a lot of success, right? We did see members participate in care advocacy for imaging, surgeries, replacements, spinal fusions. Now you as a broker have the opportunity to say, hey man, I saved you guys over $70,000, $100,000 on like a 10 life group because membership participated with this cool program that I presented to you. Right. So it kind of goes both ways, but it's a really powerful tool as far as education goes, especially when you're talking about the next cycle. Now, I guess in that same note, because I don't want to say a different model, but it is a different approach to some extent, just because you will have an advocate reach out to the member. Like members can still go anywhere, but we will reach out in the event that we are notified, via prior auth, benefits and eligibility, or the member calling in. We actually will host an open enrollment meeting where we get to meet the broker, the C-suites, if you guys want us to at least. But in our small group, it is pretty standard. Most brokers want us to. Our account managers will be on the phone. We'll walk you through how to maximize your benefits, what it looks like, what it feels like, when you're going to get your ID cards in the mail, all of that stuff. And it's very streamlined. So like, let's say we sold a group for 6-1. We would set up a meeting. You guys would hop on. We'd educate you about how to maximize the benefits of the plan. Bada bing, bada boom. You go live, and next thing you know, people are calling in asking about how you can get free healthcare. what's really cool is once one person does it, it's funny how offices work. It's
Right.
just like school, right? Like it just catches on like wildfire, and next thing you know, we've actually had just on our larger groups, I'll give you an example. There was like a 5,000 life group we have. And literally after the first probably 2 or 3 locations started having participation with our care advocates, we had people calling in just like, hey, I heard you can get your doctor for free. How do you make this happen? And we ended up turning like what we thought had initially begun as a rough transition because they had come off of a fully insured model. They had gone straight into full value-based pricing, right? Very different than what Peony is, but it was a change. And they're actually now going on probably 5 years with us, which is pretty neat. I mean, it's pretty cool. So that's just one opportunity that we have availability to. As we discussed, the larger group, right? We're offering custom.
And where does a large group start for you guys? I can't remember the number off the top of my head.
Typically about 100 employee lives. Okay. Now, multi-location, individual billing for each location, individual reporting, that's no problem for us. We do that all the time. Same with like, chambers, associations. We typically go out with, custom set benefit plans. Here's 4 or 5 custom plans. You guys tell us what you want, blah, 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 blah.
And with you guys, does everybody have to enroll in the same plan, or there can be a kind of like a high, medium, low on the table?
Gotcha. Yeah. So we offer 2 plans at 20 lives. And then as we go up in like group size, you can just offer anything under the sun. I think it's sort of pointless to like offer, more than 5 plans unless you're a huge group.
Sure.
But yeah, we start 2 at 20 and then just up from there.
Okay.
Now we do have a solution for like the 1099 and independent workers. That is, it's a whole separate program. But when we talk about, like the franchises or like associations, like affinity programs, we'll typically go with our 1099 solution. And then we'll add in, individual group underwriting if the affinity program wants that available to them.
Okay.
So just a bunch of options on the table that we throw out there. That's in a nutshell, who we are.
Awesome. And you don't have a maximum, right? So like if a group of 15,000 came, y'all can still handle that.
Yeah, easily done. One of our longest clients is over 70,000 employee lives. Okay. And we've held that contract we actually just renewed it for another 5 years. So we're going on over 2 decades.
Right.
So yeah, no stranger to that.
And all nationwide, no issues?
Yep, every single state we can write.
Okay. What is your coverage like in Ohio? For some reason, with the few groups that I have in Ohio, I've got 3 groups in Ohio. Each one is with a different carrier. All 3 struggle with network availability. And I don't know why. It's the weirdest thing because they're all 3 on different networks, but all 3 of them struggle to find a provider that's willing to bill in network, if you will.
That's really interesting. So from our standpoint, like I said, under the Peony model, we'll go out with that PHCS extended PPO wrapped with PNOA. Collectively, you're accessing like just shy of, I think, probably 2 million providers, if my numbers are correct. Now, those aren't the only options we have access to. We actually administer over 300 different types of benefit plans. And with that many different types of benefit plans, we've integrated with pretty much every network under the sun. So from a Buca network standpoint, we can provide Cigna. Once you start getting into like the traditional self-funded networks, PHCS, PNOA, First Choice, First Health, Encore. I mean, you name it, we're probably integrated with them. So depending on the geographic location of the group, we'll pick which network, or you can tell us which network you want, and we'll get it done.
Okay. And then specialty like ongoing physical therapy or speech pathologist. I've got a client that her son will most likely always be in speech pathology for the rest of his life. And he goes to 2 appointments per week right now. and it'll bump down, they're hoping, once he turns like 6 or so, once his brain starts developing a little more. That's not an issue with you guys?
No, in fact, that's a perfect opportunity to bring in our care advocate team.
Okay.
So as you know, speech pathologists, that can get kind of expensive,
Okay.
right? Especially if you're going 2 times a week.
Yeah.
So what we'll do is we'll bring in the care advocate unit and we'll negotiate, hey, we're looking to set up another 50 visits. Okay. And we can pay you for those 50 visits right now.
Okay.
That's a powerful tool, right?
Right.
And so, yeah, that's how we would handle a situation like that. And from the group standpoint, you save a bunch on utilization, right?
Right.
That overall expense drops tremendously. But yeah, it's a powerful tool. That's a powerful tool.
Awesome. And then for groups that have had insurance before, when quoting, do you guys need claims history, or that's kind of a non-factor because we're looking more at care advocate use, or what's the preferred submission on that?
Great question. So we have 3 capabilities. Your traditional underwriting with claims data, that can go for any group size, 2 employees all the way to 100. But at 15 employee lives, we can actually start doing AI underwriting, where we can just take the census and the renewal, and we'll offer a firm proposal off of that. If it's under 15 and you don't have claims data, then we're looking at medical apps.
Okay.
But I'll tell you what, we all know it. Medical apps will always provide the most accurate underwriting.
Okay.
I mean, that's just, AI has not gotten to the point where it's still really accurate. You're still going to get like a 99% hit rate. Nothing is more accurate than a medical app.
Right.
Yeah.
Right. So I've got a group that I am currently re-quoting. I think I've turned it into you, but one of the members has had a lot of heart stuff happen, and so they're not going to be re-quoted with the previous carrier. However, he is currently applying for full-time disability, where anything he has would be secondary to Medicare, Medicaid options. Is that still a group that Peony would take on? Is it helpful to know that information, that in 6 months he will have this as a secondary? So although claims might be high, or he might cost a little more going into it, that 6 months from now the group wouldn't really have a lot of cost for him, or how would that work?
No, it would absolutely be critical to tell us that, because if we just see that, we're going to assume that he's going to be on the plan for the whole duration. And then at that point, the rates are going to be higher. But you tell us that up front, we can factor that into underwriting. But I will say, self-insured plans or self-funded plans or level funded plans, as Peony is, aren't designed for everybody. Out of 100 groups, 50 of them probably should be on a fully insured program. I mean, if you have a 10 life employer group and you have like an end stage renal person and they don't qualify for Medicare yet, I mean, yeah, I would suggest they move to a fully insured plan,
Okay.
But yeah, I would say send that over. I always tell my distribution partners, send everything our way. We do have a bunch of active benefit plans. We typically can find a fit for everyone.
Okay. Okay. Awesome. Well, that's kind of all the questions that I had.
Perfect. Just gonna see here. Record to the cloud. Yeah.